Care. I thank you very much for joining us today on this GoToMeeting. Wonderful presentation that was coordinated with Dr. Schultz and presented by Dr. Maki. Before I get into the presentation, I do want to remind everyone we have a lot of people on the call. Please mute your phones. And then if you do have a question, please use the chat box in your upper right-hand corner. And that's where you can put, and we are monitoring that, and we will share those questions. There will be time at the end also for additional voice questions. So with that, I will bring up the distinguished Dr. Barclay Schultz.
Yes, I am the roar of the crowd. So I'm Barclay Schultz. I'm the president of the Medical Society here in Sauk County. No one elected me, no one wanted the job, and now I can't get rid of the job. I thought I'd given it away last year, but in fact, the person called me back this year and said she didn't want it. So I may die in this position. So Dr. Maki's been coming out here for 35 to 40 years. He has Sauk County, he hunts here, and he talks here. He was born in Edgar, Wisconsin. He was educated at UW, both for undergraduate and medical school. He trained at the CDC and then at Harvard. He talked in 2001 about anthrax after 9/11, and 200 people, our biggest turnout ever, packed the Willersheim Winery for that presentation. In 2003, he warned us about the SARS pandemic, and that was another coronavirus. And then he was back in 2012 and talked about the MERS epidemic, another coronavirus, and luckily neither of those have turned into pandemics. For 30 years, he's been warning us about the possible pandemics that are out there to be had, and that we should be prepared. I think we are probably better prepared than the federal government. Thank you for coming up here, Dennis.
Thank you, Barclay. It's always an immense pleasure for me to come back to Sauk Prairie. And I'm really coming back to my rural roots, having been raised in a town that makes Sauk Prairie look like New York City. It was 500 people, and I consider one of the very good fortunes of my life. I've been raised in a very small, rural, northern Wisconsin town. I also very much enjoy coming back to Sauk Prairie because I've come to know many of you. I've interacted with many of you on patients, and Sauk Prairie to me represents the best in American rural medicine. And it's always a pleasure and a privilege to come back. We're going to be talking about today about a reprise of 2018. I hope it's not that bad, but it could very well be. I have no conflicts of interest, and I have an ambitious day. I'm going to try and cover 8 things, and I apologize that I'll probably try and tell you far more about COVID-2 and SARS coronavirus.
Real quick, someone on the line, you need to mute, everyone mute their phones. We're getting
Everyone mute their phones.
We're going to try and cover the outbreak that we're all experiencing. We'll talk about the biology of coronaviruses. That's a very unique and interesting type of a virus. We'll talk about endemic human coronavirus infection, and then we'll talk about the great pandemic that we're currently immersed in. And we'll talk about how we clinically recognize and diagnose coronavirus infection, and a little bit about antiviral therapy, about protecting healthcare workers. We'll discuss a lot, and we'll talk about prevention of coronavirus and prospects for a vaccine, and see what the future might hold. I'd like to spend a few minutes talking about the timeline of this pandemic. It's only been going on
I have the app
3
on my
months.
phone.
My phone, but it wasn't. I have to download it for this device too. It's currently happening. It should come up when you're
But it seems like it's forever. December,
It said I didn't have to do the app.
Hey, can everyone mute their phones? Everyone mute their phones.
picture here is of a Chinese ophthalmologist, and I find it intriguing that an ophthalmologist was the one who raised the alarm that something wrong was going on in China. And he reported a cluster of very unusual and severe pneumonias that was being seen near the end of December. The Chinese government did not look kindly on his alarm, and he was actually punished and made to publicly apologize for having been a rumor monger. Yet, several days later, the Chinese government informed WHO that they had unusual cases of pneumonia. In 7 days from that point, they actually identified the new virus, which received the name SARS coronavirus 2, because it was so similar to the SARS coronavirus of 2003, which had caused pandemic disease in almost 30 countries around the world. By January 20th, they'd had 5,000 cases of pneumonia in Wuhan, China, with evidence of spread to Thailand, Hong Kong, Japan, and the United States had its first case. On January 30th, WHO declared an emergency, and President Trump on that very same day blocked all travel from China, to a great deal of criticism, but it was the right thing to do. On February 7th, 37 days after he reported this outbreak, he died. And on that day, they had 25,000 Chinese cases. Dr. Wen Liang is a hero, and it's truly ironic that he was a victim of this pandemic disease at the age of 34. By early February, there were huge numbers of cases that were going on in China, and there were outbreaks of major size in Iran and Italy. But the United States had only had 89 cumulative reported cases. On March 11th, almost 6 weeks after the pandemic began, WHO finally declared we were facing a pandemic. On that day, we had a little over 1,000 cases, and President Trump declared a ban on travel from Europe. The Chinese on that day declared that their outbreak was over. They had controlled it, and they'd had 80,000 cases and 3,000 deaths. On that day, Major League Baseball, the NBA, the NCAA, all canceled their seasons, and all of the cruise lines suspended operations. By March 17th, Italy had had 31,000 cases and 2,500 deaths. 5 days later, we'd had 34,000 cases with 400 deaths, and New York City was starting to become inundated. They'd had 11,000 cases, and a national lockdown was instituted. On March 29th, 2 days ago, we had 142,000 cases and 2,500 deaths, and we're now pushing 1 million cases and close to 40 to 45,000 deaths. And there are large epidemics ongoing in Seattle, New York City, New Orleans, Milwaukee, Chicago, and Florida. Now, where does this term COVID-19 come from? The virus that caused this epidemic has been officially named SARS coronavirus 2 because it's so very similar to the SARS virus. Infection by this virus is now termed coronavirus infection 19, or COVID-19 for short. As you can see, the Chinese epidemic in green there, which was pretty darn large, 80,000 cases, was coming nicely under control about the time our national epidemic took off and epidemics in the rest of the world took off. It's very likely that the Chinese were not really totally honest with the number of cases and deaths that they had. This is a satellite photo that shows there was an enormous increase in sulfur dioxide from Wuhan over this period of time that almost certainly was crematoria going 24 hours a day. And from the description of people who lived in Wuhan, it's very likely the Chinese had up to 10 times as many deaths as they reported. By mid-March, a lot of people were saying, what is the big deal about COVID-19? We have flu. Flu kills 30, 40,000 people in the United States every year. However, if we compare what's happening with COVID-19, as you can see here on the right, flu kills about 0.1% of all of the victims every year. 1 out of 1,000 people who get influenza die. Right now, the international mortality is in the range of 2 to 3%. And for individuals over the age of 60, it's 6%. Over the age of 80, it's 20%. And the case fatality rate is very heavily influenced by the age of the patient. Very few people die under the age of 50, but we're seeing many, many more cases under the age of 50 in the United States than the Chinese reported. Half of all of the cases in the hospital in New York City, they have about 8,000 people hospitalized in New York City right now, are under the age of 50. But only two-thirds of all deaths are over the age of 70. Comorbidity, such as heart failure, diabetes, COPD, hypertension, cancer, all very substantially increase the likelihood that a victim of COVID-19 will not survive. Now, since the Chinese outbreak, which had its onset in January, there has been extraordinary global spread. This figure on the right in orange and yellow is the pandemic up through the end of March in the rest of the world. And as you can see, it's dwarfed the Chinese pandemic. As I said, we're close to 1 million cases, almost 10 times as many cases as the Chinese had in February. In the United States, as of yesterday, we'd had 766,000 cases and 155,000 cases and 2,800 deaths with a 1.8% mortality. And our epidemic is just starting, unfortunately. If we look at some global figures, Italy now has had more than 100,000 cases, most of it in Lombardy and northern Italy, and they have had an 11% mortality, primarily reflecting the very large number of elderly people who live in northern Italy, often in retirement. New York City is being inundated. If you read the New York Times, it's mind-boggling. several hundred healthcare workers in New York City have already acquired COVID-2. There have been 2 deaths already. 52% of all the cases in New York City are under the age of 50, those that need to be hospitalized, but 75% of the deaths are individuals over the age of 65. And this is what you see. They're almost running out of coffins. This is a reprise of 1918. Things are so desperate in terms of hospital beds, and particularly ICU beds. You're looking at the famous Jacob Javits Center in downtown Manhattan. This is being converted into a hospital that could potentially hold, they claim, up to 10,000 beds. This harkens back to 1918. This is an emergency hospital, a gymnasium in Philadelphia. They're actually even putting up tents for hospital beds.
He still does a little bit of work. He does some of the remote critical care stuff. You'll see his.
Can everyone mute their phones?
In Wisconsin, we've had a little over 1,000 cases. We've been relatively spared thus far, although they're starting to see a lot more cases in Milwaukee. So let's talk about coronaviruses, because they are really front and center at the present time. The reason that this virus has the term coronavirus is that there are these little spiked projections on the surface of the virus that allow it to adhere to the ACE2 receptor on our cells in order to inject its RNA into the cell to co-opt the machinery of the cell into making more virus. And this virus has been really very well characterized in terms of its genetic structure. There have been literally hundreds of sequences of isolates of the virus. Like all RNA viruses are different from DNA viruses. DNA viruses are exemplified by herpes simplex, varicella-zoster virus, Epstein-Barr virus. The RNA viruses are the troublemakers of human viral disease. Influenza virus, hepatitis C, HIV, Ebola, and the coronaviruses. These viruses have a very high rate of spontaneous mutation. It's why influenza changes its structure every year on an ongoing basis, and why recombinant strains of influenza cause pandemic disease every 10 or 20 years. The good news about the coronavirus is that the mutation rate is far, far less than with influenza. And that's a huge advantage for us, because if it had a high mutation rate, our hope for developing a vaccine would be very poor. As I said, the genome of this virus has been characterized in a great deal of detail. We understand quite a bit about how this virus works. Coronaviruses, as I said, are RNA viruses. They're non-segmented. Influenza viruses are segmented viruses. They're envelope viruses, which means they're very susceptible to antiseptics. And they're fairly large, almost 30,000 base pairs. And they only emerged as a distinct type of virus only 10,000 years ago. That's a blink in geographic time. Most species of coronaviruses infect animals. They cause respiratory illness in birds and diarrhea in pigs and cattle. Humans have their own coronaviruses, and there are 4 endemic strains that have been well characterized for the last 25 or 30 years. They mainly cause colds. About 1/3 of all colds are caused by coronaviruses. They only rarely cause pneumonia. Endemic human coronavirus infection is caused by these four strains, but we've had the appearance of 3 supervirulent coronaviruses that emerged from bat coronaviruses in the last 20 years that have caused 3 pandemics of coronavirus infection. We have no reason to say we weren't warned. And this is only the 3rd coronavirus pandemic of the 20th century. The 3 are SARS, MERS, or Middle Eastern Respiratory Syndrome, and then SARS coronavirus 19. This shows a dendritogram of the different types of coronaviruses in humans or animals that have been identified over the last 30 to 40 years. And the viruses we're talking about are all beta coronaviruses. They actually are a very small fraction of all the coronaviruses out there. But if we drill down on the dendritogram here, these are animal viruses that have acquired the capacity to infect humans. And they are specifically bat viruses. I find it quite fascinating that bats harbor 5 major viruses that are virulent and can be lethal for humans: rabies, Ebola, and the 3 coronaviruses. What's so striking and fascinating biologically, if we look here at the SARS virus up here, the difference between the strains in bats and the strains that can infect humans is only 2 or 3 base pairs out of 30,000. And it gives them the capacity to infect humans. It lets us realize how fragile our balance of nature is and how potentially vulnerable we could be to a mutation of a virus. And if we look at on the right-hand side here, we have SARS virus, we have MERS, and we have SARS virus 2. They are all very closely related, and they differ by less than a dozen base pairs. And they are very, very closely related to many of these animal coronaviruses, particularly bat coronaviruses. If we drill down and look at the 2 prior outbreaks that we had, in 2002 and 2003, the SARS coronavirus emerged in China. And it was very quickly identified as a bat virus that had acquired the capacity to infect civets, which is a cat-like animal that's actually eaten in the markets of China. And it made the jump from the markets to infect humans and caused a pandemic of 8,000 cases in 29 countries around the world. This was a very virulent virus. It caused pneumonia that had an 11% mortality, and we were spared. There was almost no SARS in the United States, but just north of us, Toronto had an outbreak of 400 cases and 40 deaths that it shut the city down for almost 3 months and cost them more than $1 billion to bring under control. And for reasons we don't understand, but we say, thank you, God, SARS went away after 6 or 7 months and never came back. In 2012, another coronavirus appeared in Saudi Arabia and contiguous Middle Eastern countries called MERS, Middle Eastern Respiratory Syndrome virus. Here was also a bat virus that had acquired the capacity to infect camels and humans. And camels were the intermediate source. People got infected drinking camel milk, eating camel meat, or being close to a camel by droplet nuclei or contact spread. This had a 34% mortality. It was a devastating disease. And this outbreak is still ongoing, but it's smoldering. It's not a very transmissible virus, and there are an occasional case, but it has not been a big deal. Fortunately, we've been very lucky. Coronavirus 19 probably originated from bats that made the jump to infect either snakes or pangolins. And pangolins are these almost ancient dinosaur-like anteater creatures that are endemic in Asia, and they've almost been wiped out because they are prized for their scales that people use to make jewelry and their meat. But there's evidence that this could have made a jump from snake coronaviruses that were acquired because snakes stalk and eat bats. It's not well known. This is a animal market, a wild animal market. Here they have butchered, and there's just almost any kind of wild animal you could imagine you can buy on the markets here of Wuhan, China. And this has been a source of 2 global pandemics of new coronavirus infection. This is a scanning electron micrograph of lung, and these little blue structures are virions, and you can see how much virus there is. Here's a lower power view, and this is an electron microscopic picture, and you can see the density of viral infection in the tissues here. It's absolutely massive. So what are the clinical features of coronavirus 19? The first thing that the Chinese data has shown us, unfortunately, they did a lot of testing. They did many hundreds of thousands of tests, millions of tests, literally. They were able to show that probably 80% of people who become infected either are totally asymptomatic or they may have a very mild illness with a little fever. Only about 15 to 20% come to medical attention and need to be hospitalized. They're fairly sick. And about 5% are very sick and they'll need to go to an intensive care unit and probably go on a ventilator. And about 2% of the Chinese cases died, if that's accurate. The mortality has been higher elsewhere in the world, which makes me suspect the accuracy of their data. The mortality in Spain has been 5% to 6%. In Italy, it has been 11%. The United States to date has been about 2%. There are 3 features that are almost uniform for symptomatic COVID-19 infection. Fever, a dry, minimally productive cough, and short of breath. Now, some people will have a little bit of diarrhea. There's not characteristically the nasal congestion we have with influenza. That's a difference. And if we compare COVID-19 infection and the common cold and flu, people who have symptomatic COVID-19 virtually always have fever, which is why we screen for fever at the doors of our hospitals. You don't have fever with a cold. If you've got fever with a cold, there's something else going on, such as complicating sinusitis or bacterial pneumonia. Flu commonly has fever. Flu also has a cough. Flu doesn't usually have shortness of breath, but it's easy to mistake flu for COVID-19. And we have been adhering to a false paradigm for testing. We've been told, test for flu. If it's negative, maybe they have COVID. If it's positive, you can exclude COVID. That's wrong. It's very common to have flu and COVID together. That's been demonstrated many times in many hospitals. Headaches are not common with COVID. They're very common with flu. Myalgias are not as common as they are with flu. Sore throat is not very common with COVID, whereas it's very common with the flu. So the sequence is the person has fever, they're extremely tired, they've got a dry cough, That's the first day of their illness. Within a day or two, they are dyspneic. They may be saturating just fine, but they're dyspneic. If they are starting to become hypoxemic, they're going to be admitted to the hospital. By about a week of illness, if it's going to happen, they'll develop significant respiratory distress, need to go to an ICU, need to be put on high flow oxygen, and if they get better, they usually get better within 2 or 3 days. That's been our experience. They're usually better within about 3 days. Those who don't get better go on to die a week later, or at the onset of respiratory distress, they spiral down with a cytokine storm of shock and total organ failure, and they can be dead in 12 hours.
So if that fever goes down, are they spreading viral? If the fever ends in 12 days?
No, they're still infectious. The median duration that you can detect virus in the respiratory secretions of infected individuals is 14. That's the median. That means half the people are much longer than that. How do we diagnose coronavirus infection? Well, culture is actually pretty good, but it's very unwieldy, takes a long time, takes 2, 3, 4 days, and it's impractical, and it's hazardous. Laboratory personnel are very vulnerable. This is a very contagious virus. During the SARS epidemic, a number of laboratory personnel became infected processing respiratory specimens. So these need to be processed in a hood. The cornerstone of diagnosis has been real-time PCR. That's the gold standard. It is not 100% sensitive. We're going on the assumption it is by the decision making we make. If it's negative, we tell them you don't have COVID-19. Well, I hate to disabuse people, but the PCR is not 100% sensitive. We don't know with certainty how sensitive it is. There's a desperate need for a prospective study where you do daily cultures and PCR for individuals who've been heavily exposed and they're known to be negative, and you wait till they turn positive to find out how sensitive is PCR, how long does it stay positive, how accurate is it after the onset of illness for indicating persistent contagiousness. We don't know that yet. It's very likely that a serology will become available shortly, and it's very likely it'll be very helpful. But even if I have a positive IgM, my IgM could be positive for 3 months. It doesn't mean I have active infection. So if you have a positive serology, it needs to be confirmed with a PCR. A very important point, when you get your specimen, the PCR is only validated for nasopharyngeal cultures, not throat cultures, not sputums. It probably works, but it's not been validated, it's not been tested. And it's extremely important that the swab is put all the way back till it touches the back of the throat. And if the person doesn't really jump back and you know how deep it is, you want to look at the swab, you may miss a true infection. It's very important for nasopharyngeal swabs for meningococcus, for pertussis, for anywhere where we use nasopharyngeal swabs for diagnosis of infection. You need to get all the way back to the nasopharynx, not the nasal passages. This pneumonia has some very characteristic radiographic features. It causes subpleural infiltration. You can see in the top panel the ground glass change that's subpleural on both of the images. The lower one is turned into frank consolidation, and there's patchy consolidation in the lung fields. This is so characteristic that Chinese physicians felt they could accurately diagnose COVID-19 before they had the results of the PCR. And when they saw this, invariably the PCR would be positive. How do we manage COVID-19? Is there any role for antiviral therapy? If they're not sick, they don't need to be hospitalized, but they need to be in home quarantine, strict home quarantine. They're highly contagious. The undiagnosed subclinical infection poses the greatest risk to society. If they're sick and they're diagnosed, they're going to be hospitalized. The first thing you need to do is make sure there isn't something else than COVID-19. Make sure it's not influenza. Make sure they don't have a secondary bacterial pneumonia. Bacterial pneumonia is fairly common for sick COVID-19 patients, no different than flu patients. If they're on a ventilator, you need to look for Pseudomonas pneumonia or staph pneumonia. If they've been on a ventilator for 2-3 days, they're not doing well. And often we find that. They need to be put in appropriate isolation, which we'll talk about in much detail shortly. And even if they're out on a general patient unit, you need to monitor the saturation continuously. This is the marker for progressive disease. They all tend to complain of shortness of breath, but only when they start to desaturate on room air, they need supplemental oxygen. They need to be monitored very closely. If they start to desaturate, we put them on supplemental O2, quickly transitioning to high flow. We rarely use BiPAP on these patients because it generates such aerosols, infectious aerosols. If they are in the ICU and they're becoming more hypoxemic, once we get up to 50 to 60% FiO2, we intubate the patients. What about antiviral therapy? Well, I didn't know that we found a cure for COVID. I'm not reading my literature the way I should. It turns out that there are a number of antiviral drugs that have come down the road in the last 20 years, only some of them which have come to market that have in vitro activity against both SARS coronavirus and coronavirus 2. And I cannot emphasize how similar SARS viruses and SARS coronavirus 2 are. They are literally, they're not even fraternal twins, they're almost identical twins. They are so similar genetically and in terms of their biologic properties, in terms of their epidemiology, in terms of the clinical illness that they produce. They are very, very similar. The two drugs that have been used most widely have been chloroquine or hydroxychloroquine with azithromycin, or lopinavir-ritonavir, which is a combination of protease inhibitors used for treatment of HIV infection and AIDS. Remdesivir is a new broad-spectrum antiviral that has hope for promise for treatment of COVID-2. These are experimental antivirals that have had vitro activity, but they have only been started to be studied in experimental animals. They're a long ways from clinical trial. We also have biologics such as convalescent plasma from individuals who have survived COVID-2. They have high titer antibody. We can make monoclonal antibodies fairly easily. We can use interferon, which is helpful for other viral infections. And we have this anti-IL-6 monoclonal because many patients who develop septic shock and organ failure have very, very high titers of cytokines. None, let me say it again, none of these drugs has been shown to be effective in a trial. None. And I'm frankly, personally frustrated to the point of tears is what's happened internationally. Everybody dies on an antiviral. I can understand. Don't just stand there, for God's sake, do something. Why I'm upset about that is empiric therapy gives us no answers as to what works. Nobody can claim with any certainty that their patient's life was saved by a drug or they died because the drug was not effective. You can't do it. And the only way we're going to find an answer as to what works and what doesn't work with COVID-2 is going to be large, multi-center, randomized trials. But these are simple trials. They're much simpler than chemotherapeutic trials, much simpler monitoring. Outcome measures are very clear-cut. You start people on therapy who are symptomatic when they come into the hospital, and do you diminish the number who go to an ICU? Do you diminish mortality? Do they get better faster? Objectively, compared with the placebo group, there has to be a placebo group. You can answer no questions. And by touting drugs such as chloroquine, patients in droves are demanding chloroquine. Physicians are prescribing chloroquine. Physicians are doing dumb things, such as prescribing a fish tank cleaning preparation of chloroquine that has killed patients. It's crazy. It's absolutely crazy out there. We give chloroquine. We have been unable to get remdesivir. We give lopinavir. There's one randomized trial from China, fairly good size, not the slightest evidence that had any effect. I'm frankly very disappointed that we've had 3 months lead time. By early February, it should have been clear this is coming. Tonight, we're going to sit down as a committee. We're going to write a randomized trial. I can write a trial in 12 hours. A lot of smart people can vet it in a day. It can be approved by an IRB in another day. They have simple outcome measures. You can start enrolling patients, say a 6-arm trial.